Good morning. I'm Pat Croce, and this is the American Cancer Society's Healed Community Gathering. We're here every Wednesday at 11 o'clock Eastern Standard Time. As the gathering grows and grows, our intention is to educate, inform, inspire, and encourage you to live healthier lives in the present moment, body, mind, and spirit. I'd like to thank our presenting sponsor, 6ABC, our leadership partners, those 30 individuals who ponied up large amounts of money to help us raise our first $2 million so that the HEALed research can get underway in Atlanta. And to each and every one of you who are wearing our HEALed bracelet, you went to acshealed.com, made a contribution of any amount, and we ship you out this bracelet. And that green bead, that stands for unity, nature, healing, harmony. We're all in this together. One being, many expressions from the one essence. We start each gathering the same way with just a moment of stillness, because I want the past to be the past and only to be in this sacred space of the present moment. So I'm going to ring this little Tibetan bell. Just place your attention lovingly, gently on the sound. That's our doorbell. That opens up the door to the HEALed gathering. Welcome again. This is a unique community. Grace has touched you to be part of us, and we have some great guests every week. This is our 24th gathering. And our guests today, we have three wonderful guests. Normally we have two, but we have a special guest starting us, Cindy Stutman. Cindy is the executive director, the senior vice president first, of the Philadelphia Flyers and the Wells Fargo Center, and the executive director of Flyers Charities, which I love. I was part of them for 14 years when I was the physical conditioning of the Flyers. And Cindy, welcome to our gathering.
Hi, Pat. Thanks so much.
It's great to have you. And I really love what you do with Flyers Charities, but most people may not know exactly what the intention of Flyers Charities is.
So we have three pillars that we focus all of our giving on. The first is most important, especially for this group today, is for families impacted by cancer and people going through cancer. We try to support them in any way we can. Our second pillar is growing the game of hockey to diverse audiences and getting new diverse participants to play the game. And our third pillar is sustainability and environmental responsibility.
Well, before we go to the cancer, tell me about the last one, the sustainability. What exactly is that?
That's actually new to us this year. We've just relaunched our mission.
That's a new one because I never heard that. So yeah, I'm interested.
We've just actually publicly rolled it out in the last week or so. And we're working hand in hand with our arena, the Wells Fargo Center, who has taken a lot of attention towards this area as well. And we're going to work together to really give back to organizations in the community that are doing environmentally responsible initiatives and have missions. And we're still working through exactly what that will look like on the giving end for us, because there's a lot of really great organizations.
Well, that's exciting for you. You get to open a brand new door.
Yeah, we're super excited.
And one door you've opened for us, ACS HEALed. HEALed stands for everyone's information. HEALED, healed. We're all healed. Health and energy through active living every day. Health and energy through active living. And that can be defined as movement, just getting off the couch and whatever you do. You don't have to play professional ice hockey to have active living. Every day, that's the key. And I want to thank you, Cindy, and the Flyers Charities for your recent multi-year commitment to our HEALed movement. It is truly a movement. And thank you. And why? Why did you commit to us?
Well, when we first talked to your team, it was just really a natural fit. One, because of our mission, right? And we're all working together to impact the lives of people going through cancer. But as part of the mission of HEALed, we have a gritty 5K that we're hosting on November 6th, starting at the Wells Fargo Center. And we call this the 5K for everybody. It can be an anti-runner's 5K. You just have to move from the beginning to the end. We don't care how you get there. Walk, run, crawl, drive it, whatever you want to do. And it's a lot of fun. There's a lot of activations. Gritty's handprints are all over it. And there's a lot of really fun stops along the way. And immediately when we talked to your team, we were immediately brainstorming on how we can work together to make this really great. And we had a lot of really good ideas that you'll see in practice, I think, on November 6th.
So it's November 6th, the Gritty 5K. How can people register?
They can go to flyerscharities.com and just click on events, and you'll see everything you need to know about the Gritty 5K. Sign up is easy. You get a great kit, a great t-shirt, and we encourage costumes. The more gritty you can look like when you come down, the better. We'll have prizes for best costume and a lot of different things along the way. So we encourage fur, orange, face paint, whatever it takes. We've had some really good costumes, over the first couple of years, and we're excited to see what's going to be down there on November 6th.
And everyone, a 5K, a Gritty 5K, named after Gritty the mascot, a 5K is about 3.2 miles?
Yeah, just over 3.1.
So everyone, as Cindy was saying, you can walk it, jog it, run it, roller skate it, skateboard it, whatever you want to do, just to get the movement, health and energy through active living every day. And before I let you go, Cindy, November 6th, the Gritty 5K, and you can go to flyerscharities.com to register. Please do. We were talking off the air about the commitment that the Philadelphia Flyers teams makes to Flyers Charities. Can you just briefly share with us, and then we'll let you go because I know you have meetings.
Yeah, thanks. I actually just finished meeting with our team this morning and going through a list of all the charitable efforts and events, including the Gritty 5K and some of the community initiatives we have going. And they're all committed to sign up to be a part of one or more of them. And we're going to work together on the business side, on the hockey side, to really make the biggest impact we can in the community. And we're super, super excited.
Leave it to the Flyers. Bleed that orange. Cindy Stutman, thank you. Thank you very much for joining us today. And we'll see you on November 6th.
Thanks a lot.
Bye-bye. Bye. Again, if you're interested, please get involved. Monies are helping HEALed. Right, HEALed. Health and energy through active living every day, November 6th. That's the Gritty 5K down by the arena. My next guest is Dr. Timothy Dambro. We try to have a medical specialist as well as a warrior, someone who is surviving their cancer treatments, their diagnosis, and making an impact not only on themselves, but on the community at large. Dr. Timothy Dambro is a staff radiologist. We've had orthopedists, we've had oncologists. Now, Dr. Dambro is a radiologist at the Delaware Imaging Network. And he's got his resume is so long. A fellowship in ultrasound from Duke University Medical Center, a fellowship in women's imaging from Hospital University of Pennsylvania, a graduate of diagnostic radiology residency program at the University of Connecticut Health Center. He's coming to us right now from Vermont on his vacation, and he specializes in mammography. Now, you're going to hear about why you should be screened, and no one is more important to tell you than that individual who places the diagnosis on women when he finds something. Dr. Timothy Dambro, come on, Dr. Dambro.
Good morning.
Thank you. Thank you for joining us.
Thank you. Thank you.
I love the color.
I just changed because Diana said I might be seen here, so I thought I'd better put on the pink.
No, I love the pink. Real men wear pink, right?
Exactly. That's one of the offshoots of Making Strides Against Breast Cancer from the American Cancer Society. Real men wear pink.
And aren't you part of the leadership of Delaware, the state of Delaware, for the ACS?
Yes.
Well, thank you for that.
Well, more so Making Strides Against Breast Cancer Committee. Real Men Wear Pink is kind of taking a little back seat this year, mostly because of COVID. So we're just getting back into the swing of things now. Real Men Wear Pink will come back up probably next year, full strength.
Gotcha. So why don't you share with us your career path, your medical career path, and what led to this imaging specialty?
I guess early on in my residency in diagnostic radiology, I looked to an area where I had the most patient contact. And now things have changed during my career, but back then, with mammography, breast ultrasound, breast MRI, breast biopsies was the area where you got to speak to the patients. All the other areas, patient comes in, gets a CAT scan done, get an MRI done, an X-ray, they're gone. They never even know who the radiologist is until they see the name on the report. Where in women's imaging, you're interacting with the patients, and I think that I just gravitated towards that area early on.
I can
And
see that
it's a good fit.
personality of yours would be that energy is beautiful.
Thank you. I try. Early on in my career, I remember one patient said she had a diagnosis of breast cancer. She came back in for, a screening or something. And, everybody in the area was kind of somber. And she said, no, don't do this. She said, I have breast cancer. I'm not dead. So don't treat me like I'm any different than somebody that you would go out and have a drink with. And so we see a lot of horrible things in our offices. But we try to, and especially for the staff that you're working with, we do see some horrible things. And so you've got to kind of be have a little levity in what you do and the work that you do. Granted, it's very serious, but you have to be somewhat upbeat about the whole thing. And even if you do diagnose a breast cancer, is telling the patient, hey, look, your next year, your next 6 months, you're going to go through hell, but on the other end of it, you're going to be fine. Women don't die from breast cancer like they used to years ago.
Right there, just that input from you, that must make quite an impact on your patients.
I hope so.
How difficult is it, or easy, to diagnose some malignant change in the tissue?
As far as the technology is concerned?
Yeah, the technology is one thing, but you have to still place a diagnosis.
Right, exactly. But early on, before my career started, we used to have things called zero mammograms, where it was basically an X-ray of the breast, which in retrospect were absolutely horrible. And the technology has advanced so drastically in the past 10 or 15 years, and every year we're improving. And so the technology is what helps us see the small cancers. Yes, some patients will say, well, thank you for doing what you do. And it's kind of like, no, I didn't detect the breast cancer. Somebody up above me is looking through my eyes and helping me see what it is that's on there that's going to detect your breast cancer. The thing that women have to realize is that if they don't come in, we can't diagnose. It's kind of the thing where, like, you can't win the lottery unless you play. So if you don't come in and get your screening mammograms done, and if you don't get it done every year, we don't pick up the small 2 and 3 millimeter cancers that we want to do. So it's also patient driven. Patients have to take a certain responsibility for their screening, for their healthcare.
You just made great points there. However, one point I'd like for you to share a little more. When they do get this screening, and there is a very small, noticeable diagnosis, how effective is this screening for the prognosis?
Well, so a woman gets her screening mammogram. Now we've come to the age of 3D with tomosynthesis, so multiple slices is kind of like taking a CAT scan through the breast, as opposed to just the original 2-view mammogram. Makes it, I shouldn't say it's easy, it's easier for us to diagnose. So the patient comes in a 2 millimeter cancer. Most of the times we find it. Also depends on the breast density. We also have other techniques available to us, other imaging modalities available to us. Screening breast ultrasound, screening breast MRI, which if you're at high risk, is recommended annually in addition to the mammogram. So
can you stop, Doc? Doc, can you just define high risk?
Sure. So high risk, defined by the American Cancer Society, is actually anyone who has a risk of over 20%. There is a model that we use in breast imaging. Most women can get their breast risk if they look at their reports from us, if they go to their doctors, their primary care, or their OB-GYN and say, what's my risk? So you can, it's evaluated based upon your age, your family history, which you can't do anything about, your breast density, which you can't do anything about. It's based upon your first period, when you went into menopause, your first birth, whether you breastfed, things like that. There's multiple things, and including BMI. The more obese you are, the American Cancer Society will tell you, watch that weight. Obesity is related to breast cancer. So values come up. And when it's like 15 to 19, it's considered moderate risk. When you're over 20%, then you're considered high risk for developing breast cancer in your lifetime, based upon many things, not just family history. So when it's over 20%, the American Cancer Society, the American College of Radiology, the American College of Breast Surgeons recommend that you also are screened with breast MRI. A lot of women don't know that because they don't know that they're at high risk.
Wow.
Education is the key here. And that's on us. American Cancer Society does their part. That's on us, the breast imaging division, society. I mean, that's probably the biggest problem with getting women in for screening. They're not educated. Women will say to you, well, I don't have any family history, therefore I'm not at risk. Well, 75% of breast cancers that we diagnose every year are women who have no family history. So
wow. Wait. You gave so much great information. Just defining high risk doesn't necessarily mean a family history. Say that again. 75%.
Over 75% of women who are diagnosed the first time with breast cancer don't have any family history of breast cancer. 75%. So women who say to you, I don't have any family history, therefore I'm not at risk. Well, your risk are 1 in 8, which is the national average. And 75% of women diagnosed don't have a family history. So you can't go by. So going back to the point you tried to make is, can you have a risk of over 20% and not have a family history? Yes, you can.
Wow. So whose responsibility is it to educate women?
Oh, that's a tough one. We try. When women come in and I meet people on the street.
Yeah, but they're already coming to you. I want those that aren't coming to you to come.
Exactly. How do you get to those people? We have Making Strides Against Breast Cancer, which is one of the aims is to raise money for breast cancer research and the programs that the American Cancer Society has. But for me, just as important is getting awareness out there, getting the message out there. The facts that I just told you, the importance of screening mammography, the importance of self-breast examination. We have women who are coming in their 60s and 70s, and it's their baseline mammogram. You say to yourself, where have you been? Where's this woman been all these years? You find that their primary care physicians or their OB-GYNs or their family practitioners tell them, go in and get your mammogram done, and the woman refuses. For several reasons, there are many, but even so, you want to pick out those cancers when they're 2 and 3 millimeters. And if they haven't had a mammogram in 10 years or their baselines at age 55, you got one hand tied behind your back already.
Dr. Dambro, is there an age a general age, like we have our prostate or a colonoscopy for men 40 years old and guaranteed at 50, but is there an age that you recommend for women for mammography or any of your testing?
Okay, so the American Cancer Society recommends that at age 40, you at least talk to your provider about getting screening mammography. So yeah, 40 years is probably it. Now, if you're at high risk, it could be earlier. It could be 30. So that's why it's important to know what your risk is. Now,
we're at that catch-22 again. We're at that. There should be something in high school where every woman gets this calendar of risk factors that you mentioned so subtly. That whoa.
So there's the thing. You talk high schools, okay? So early on in my career, I used to, during the month of October, we're trying to recruit interest in making strides against breast cancer. So I'd go and I'd talk to local high school assemblies, along with the representative of the American Cancer Society. I'm the unpaid representative of the American Cancer Society. So you want to get to those kids, and I would bring along, one time I brought along a woman with me who was 22 years old, who was diagnosed with metastatic breast cancer. Unfortunately, she died 3 years later. But that woman had more impact upon those kids who were 16, 17, 18 years old than I did, spewing a bunch of facts. So yes, we need to be teaching in high schools that, there are some women who, are 30 years old because of their family history, because they're at high risk, should be getting screened at 30, not 40, not 45, not 50. So education. And Pat, I agree with you. It's like, how do we get it out there? I mean, we're good at what we do. We're very good at what we do in diagnosing and doing the biopsies and reading the breast MRIs and getting the patients to the breast surgeon for their lumpectomies and radiation and chemotherapy. We also try to be out in the community. I mean, I think that's part of the reason why I volunteered with the American Cancer Society since it first came with Making Strides to Delaware 19 years ago, is get the message out there. But there's women are sometimes they're stubborn. Even when they have the knowledge that they should be doing it, sometimes they don't show up.
So one question, and obviously I don't know anything about a mammography, but is there any pain involved in this screening?
Okay, so there's compression. Okay, so some women will complain about the compression. In reality,
Define compression.
I'm sorry?
Define compression.
So the breast is put onto a platform, and the breast is compressed. The more that you can compress the breast, the more that you spread dense tissue out. So in other words, just think about it. You've got this sphere, and you've got an x-ray going through it, but there's all this tissue in the middle. And so the less you compress it, it's like things are superimposed. The cancer could be hidden. So you want it compressed as much as possible. Most women will tell you the mammogram doesn't hurt. It might be uncomfortable. I've actually had one done myself when I had a lump. Men do get breast cancer. In fact, this year.
Whoa, stop again. Stop. Stop. Go. Men do get breast cancer.
Less than 1%. But you look at the American Cancer Society website, and you'll find out that this year alone, 500 men are going to die from breast cancer in the United States.
I had no idea.
Well, see, there's another thing, is men will ignore a lump that they feel. And
yeah, we think it's a pulled muscle or something.
Exactly. Well, some women do that too. But so, men will ignore a lump, and then finally they get to you. And, fortunately, again, it's less than 1%. So we're not missing that many. But when they do come to you, you do biopsies, and men do get breast cancer, and 500 will die this year in the United States.
Wow.
Do your breast exam, Pat.
Well, yeah. Wow. And I believe it.
So the compression, going back to your original question, because I want to emphasize that to women out there who are hearing the horror stories. Oh, I heard it's so painful. It's really, really bad. No, two things. One is the compression isn't that much. I mean, it has to be sufficient. Two, we have dedicated breast technologists. Okay. That's all they do all day long are breast mammograms. So they know how to get the patient in. Most of the time it's uncomfortable if the patient is not relaxed, and therefore they can't position them well enough to get the x-ray that you need. So a good technologist will be able to coax the patient into relaxing, and therefore the mammogram is less painful, even though a lot of times it's not painful. It's less strain on the patient's breast. Therefore, she doesn't complain about it. Very few of our women complain about that. That's all I can say about that.
I think the information you're sharing is just wonderful. Not only the percentages, but also, the not painful. The mammogram is so important to get it at 2 and 3 millimeters.
Yes.
Before tiny.
Yeah.
Tiny. And so how about this whole past 2 years with COVID? Have you seen, or what have you seen relative to screenings?
So screenings have gone down. Screenings went down the first year. So back in April and May of last year, normally we see in our offices maybe 200 screening mammograms a day. We were down to maybe 10.
Wait, 200 down to 10.
Yeah. Well, but with reason. In other words, we were in shutdown, right?
Right.
So whatever it was, and the American Cancer Society can tell you this, maybe Diane can tell you this more than I, is everything was down as far as screening was concerned. Colonoscopies were down, prostate exams were down, screening for your teeth, everything was down. So, but then what happened is then come June of last year, all of a sudden we rebounded. And so now we're at a point where we're back to where we were before COVID, although I think that the numbers nationally are down. I was just at a meeting a couple months ago, and they spoke about Delaware. Delaware is not across the board, is not where it should be for screening mammograms. We raised our hands, we begged to differ. In our offices, we're beyond that. And maybe that's marketing, I can't tell you that, or maybe it's the patient population that we have where they're coming back to see us. But we're at a good place post-COVID.
You're at Delaware Imaging Network?
Yes.
And the network has how many facilities?
So there are 8, and we do breast imaging at, I believe, 6 of them.
And do you circulate from one to another, or are you located at a special one? So if I want my wife to come see you, where are you?
Okay, so there are 4 of us in the breast division, and I'm the traveling one. So I'm the only male. Maybe that's part of it. But anyway, so I go to all the offices where we do breast imaging, and I read what's called their diagnostic exams that day. The biopsies are all done at one site, which is in Newark. And so I may be there 2 days a week, 3 days a week. It depends on who's on vacation, who's off. But yes, I like it. I get to rotate. I see a different population of technologists and patients too.
So, Dr. Dambro, as a radiologist and an imaging specialist, do you ever talk to the patients and give them the diagnosis, or do you usually share it with their physician?
So woman comes in, gets a screening mammogram. It can be done at any of our facilities, and it's usually read by one of us in the breast division, even remotely. It's all computerized. So then if you see something on that screening mammogram, the patient is a callback. She has to come back for additional diagnostic workup of whatever it is that you saw on the mammogram. And something for your listeners to understand is just because you get a notice that you're a callback doesn't mean we found something that looks like it's cancer. You might be called back for things of what we call superimposition of tissue. Maybe it needed a little bit more compression. Maybe you need an ultrasound to show that the mass that you saw on the mammogram was not a solid mass, but was a cyst, nothing to worry about. So there are callbacks. Then when you have the patient called back and you see something that is suspicious, you recommend a biopsy. And then the patient will come back another day for the biopsy. We do the biopsies in our offices. That can be either ultrasound guided, it can be mammography guided, or it can be MRI guided. You do tiny little biopsy. The patient goes home. You send it off to the pathologist. The pathologist calls you back and says, this one's cancer, this one's benign. Then when it's cancer, you, the person who did the biopsy, the breast radiologist who did the biopsy, you pick up the phone and you call the patient. And you say, hey, Mrs. Croce, it's Dr. Dambro from Delaware Imaging Network. I'm sorry to tell you, but that did come back as cancer. And so then you go through the spiel of whatever questions the patient may have. You know in advance who her referring physician wants you to refer her to a breast surgeon. So you say, I spoke to your doctor and he wants you to see Dr. So-and-so as a breast surgeon, and I will explain how that's going to happen for you. And then we will facilitate the appointment. So yes, we are the ones who tell the patient that the biopsy came back as positive.
And how receptive are they to you?
I don't think, Pat, of all the years that I've been doing this, I've ever had a patient. You run the gamut as far as sometimes the patients say, thank you so much, and hang up. Other patients will cry. Other patients will say, what do I do now? Very rarely will you get a patient who is angry with you. Because women are scared. Even women who come in for their screening mammograms, sometimes you have to tell your patient service representatives at the front desk and your technologist that you have to be considerate of the patient's anxiety. She's coming in to get screened for breast cancer, and so they're not always nice. Okay. So you have to realize, like, some of their anxiety is driven by what is going to happen to them. So some patients will react adversely to you about the biopsy, but 2, 3 in my career, most of them are very appreciative of what we've done. Yeah,
I would think all of them. I would think
sorry?
all of them. I would think all of them are appreciative.
Yeah, in different ways. In different, the patient who says, "Okay, thank you," and hangs up. I have other patients who they'll call me back. They'll have their husband or their boyfriend or whoever, the girlfriend, call me back and say, "Can I talk to you about this case?" And sometimes you can give them some answers. Sometimes you can't. More of it's going to rely on the breast surgeon they see and whether they're going to need chemotherapy, radiation, in addition to surgery.
So before I put you on the bench and bring out our next guest, what, Dr. Dambro, advice could you give our general population right now? Well, one piece of advice.
Screening mammograms every year. Know your risk. If you don't know what your risk is, you get a screening mammogram, ask them to run a risk for you. If they don't, ask your primary care. You may be needed to be screening before the age of 40. You may be needed to be screening at the age of 30. You may need additional imaging with breast MRI. Know your risk. But I guess the most important thing is get your screening mammograms. Get them every year. Don't skip a year. Don't skip 2. Don't think like, oh, I'm just too busy. There's always, we hear all the excuses. Get educated. Get your screening mammograms.
Dr. Dambro, I love you. You are great. you get on my all-star doctor team. So I'm going to ask you just to sit on the bench in your hotel room there for a little while, and we'll bring you back in.
Okay.
My next guest is Brandi Plutnik, and Brandi had a diagnosis of breast cancer. And I'm going to let Brandi share her story with you. Brandi, come on. I love her. She is one fitness junkie. Hello, Brandi.
Hello, Pat. Thanks for having me on.
Thank you for being on. Wasn't he great?
He was great, and I have lots of questions for him now. Now that I've heard him talk, and he hit on so many of the things that I also have learned this year. So it was.
And
great.
did you learn it on your own, or did someone share it with you, or did you have to question and quiz? So let's go back one step, Randy. Take everyone into your diagnosis. It wasn't long ago, and you're probably, of all of the warriors we've had in 24 weeks, the most recent. So share with us your cancer story.
Sure. So I am one of the opposite types of women that Dr. Dambro described. So he talked about women who just, don't really get their mammograms, even though they know it's the right thing to do or they should be doing it. I actually grew up with a fear of breast cancer because I watched my maternal grandmother go through the after effects of it. She was diagnosed in her 30s, and it was quite advanced at that point, although she survived for decades after that, until cancer came back in another part of her body and took her life then. But my mother and I have always feared this. And so even from my 30s, I was going to my annual gynecological exams and quizzing my doctors and being kind of the squeaky wheel. And I'm sure some of them cringed when I came in because I knew just enough to be dangerous at times. But I was pushing for mammograms in my late 30s, and I got them. So I had been getting my mammograms every year, and then.
Were you rare? Was that rare for you to be in your 30s and pushing? Did doctors coincide, or did they say, no, you don't need it yet?
I had a little bit of a mixed bag. I remember one of my first gynecologists kind of, I want to say didn't validate my concern, wanted to basically say, you don't have anything to worry about. Your mom hasn't been diagnosed. You have a pretty weak family history. But as Dr. Dambro said, there are many, many other factors that people don't take into consideration. And for me, I had always been told I had very dense breast tissue, that fibrocystic dense breast tissue that makes it difficult for even the most advanced mammogram to pick things up. And it also makes it difficult to feel a lump in your breast when you're doing your monthly self-exams like you're supposed to do. It's almost like looking for a different lump in a sea of lumps. I mean, it's just a lumpy, dense tissue. And so, but after that, I would say I had a gynecologist then that was receptive, answered my questions, and got me into a screening program. And I would say almost always was one of those callbacks that Dr. Dambro described. They were always calling me back and wanting to do an ultrasound or an MRI on something they had found. And thankfully, it was always a cyst or something benign that they could take care of or just tell me to watch. But nonetheless, it was anxiety producing every time. So it wasn't until maybe 5 years ago that my gynecologist at Penn, I go to Penn now in Philadelphia, and she told me about this fast breast MRI. And Dr. Dambro talked about that as well. And this is something that is not available everywhere, but because I'm close to one of the best healthcare facilities in the world, I have access to. And she said this fast breast MRI will pick things up that a mammogram typically doesn't. And you're not considered high risk enough because they had run that whole risk for me, using those different models, all the different factors. And I wasn't considered that high risk. And she said, your insurance won't pay for it, but it's $300. And you should get it done in between your mammograms. So you have a mammogram, 6 months later, an MRI, 6 months later, a mammogram, and so on. So I was in that protocol because I was proactive and had asked those questions and had a very proactive doctor as well. So unfortunately, in 2020, I put off my screening mammogram. I didn't put it off for long, just a couple of months. So,
because of COVID?
Because of COVID. And so in November of 2020, I went for my mammogram. I was a few months late on it. The mammogram came back negative. There was no findings at all. This is just November of last year, about a year ago today. So then in April, I was scheduled for my MRI that I was doing proactively. I had the MRI done, and sure enough, the MRI picked that very tiny 4 millimeter lump up in my left breast. So
and the diagnosis was exactly what?
So my diagnosis was called DCIS, which stands for Ductal Carcinoma in Situ. And what I later learned was that I always thought breast cancer was breast cancer. What my grandma had was what I now have. And that's absolutely not the case, thankfully. So ductal carcinoma in situ basically means you have a non-invasive cancer that's confined to the milk ducts. It hasn't spread throughout the breast tissue. And it's categorized as grade 0, actually. So, or stage 0, I'm sorry, stage 0. And there's actually literature out there that in some cases, this is not even considered a real cancer, but it actually is a cancer because you have to treat it as such. And so that was my diagnosis. And I got that diagnosis from my radiologist at the time.
And the treatment options were what?
So I'm one of the lucky people that had many choices. So when I went to see the breast surgeon, as Dr. Dambro described, first your radiologist gives you the diagnosis, and then you go see a breast surgeon. So my breast surgeon, Dr. Alina Mateo at Penn, who's fantastic, laid out the typical protocol for me, which, by the way, I already knew because I had been Googling just enough to be dangerous, and I knew what the protocol was. And she said, here's the deal. You will have a lumpectomy. They will cut the lump out to get good margins. Then you're going to have a course of radiation therapy to your left breast. And then after that, we're going to ask you to take tamoxifen, which is a hormone therapy for 5 years at least. And
what does that do?
So my cancer was called estrogen receptor positive, which in short means that estrogen is actually feeding the cancer. And that's the most common type of breast cancer for women. It's usually fed by hormones. So what the tamoxifen does is it actually decreases the estrogen in your body. It puts you into kind of a chemically induced menopause, and then you don't have the estrogen feeding any more cancers. So it's supposed to be a preventive to keep any more recurrence from coming back. And that's what it does. So she described this to me. And as I do, because I'm a squeaky wheel, remember, I said, but wait a minute, let's back up, because I also read that there's another option. And that option is to have a surgical mastectomy, to just get the entire breast cut off, one or both of them. And she looked at me and she said, yes, that's an option. She said, it's a very aggressive option considering your lump is 4 millimeters and non-invasive, stage 0 cancer. But she said, it is an option, and I'll describe that now. So then she described that other path. And, that other path was getting the double mastectomy done, which.
So it's not just a single mastectomy. It would be a double.
You can do a single, but for me, the reason why I asked about the double is because I felt like that would give me the lowest chance of recurrence in either breast. Because once you've had DCIS, even though it's non-invasive by nature, it does increase your chances of having a recurrence in the other breast. And so I didn't want to go through this again. And I thought, maybe I'll just get the double mastectomy. So it actually yielded the same low chance of recurrence as the lumpectomy plus radiation plus tamoxifen protocol. And so she said, we can do this. And I assume you will want reconstruction. So you'll have to go see a plastic surgeon. And I said, yes, yes, yes. And I saw the plastic surgeon and I asked all the questions. And then I had read horror stories about women being on tamoxifen and the side effects of that. And, I want to say that Dr. Dambro was absolutely right. He touched on this. And women don't die of breast cancer when it's detected early. And both my surgeon and my radiologist both told me, you will not die from this. You will survive it. It's just a matter of how. Now, I would almost say that I was less afraid of dying of cancer than I was of living sick. In my mind, having cancer, makes you sick. You're having chemotherapy, you're having radiation, you're tired, you're exhausted. Those are the horror stories that were in my head. And for me, I was afraid of that. So I actually sought out information from women who took tamoxifen. And I said, change my mind. Tell me you're taking it and what your experiences are. And they did change my mind.
You're brilliant. You're brilliant. What a great exploration.
Talked to said, when you look at these online forums, And when you go to these support groups and things, keep in mind the women that are posting those horror stories are women who are having the side effects, and they are the minority, and they're looking for support and answers. But the majority of us who are taking these drugs very successfully aren't online posting because we're all busy living our lives. And so this opened up a lot of option for me. I really weighed both things. But in the end, I opted for the double mastectomy. And again, this does not mean that I have no chance of getting cancer in my breasts again, because your body's not compartmentalized that way. When they remove your breast, there's still residual breast tissue left behind. And yeah, I could get cancer in one of those cells again, but the chances are just as low as if I had done the other protocol.
And you have this saying that you had to train for surgery. Explain that.
Yes. So at the beginning, I really felt like my body had let me down. I got into fitness about 3 years ago, and I've been a vegan for many years. I eat a whole foods diet, homemade foods. I try to do everything I can to have good health. And when I got this diagnosis, I thought, what's the use? Like, I'm doing everything right. I still got cancer. My body's letting me down. And then it was a very wise friend of mine who said, maybe you should look at this a different way. Because you're so healthy, your body's going to carry you through this successfully. Boom. Yes. And I so wanted that to be true. So what I started doing is, just as you described, training for surgery. And that meant keeping up with my fitness routine in a slightly different way. So I do CrossFit. I'm in this wonderful community called Kana Fitness in Ambler, Pennsylvania. And I started doing the workouts, but maybe not quite as heavy. I wanted to avoid injury at all cost, of course.
And this is before surgery?
This is about a month before surgery. I scheduled my surgery, and I had about 4 or 5 weeks to get ready. So I was already in good shape, but I started, doing a little bit more mobility. I wanted to keep my shoulders and my arms really mobile for my surgery. And I also started meditating more. I love your focus on mindfulness, because I kept thinking, okay, in this moment, I'm not sick. I don't feel sick. I wouldn't know I have cancer unless I had just been told. I feel great. I'm vibrant. I'm young. I'm healthy, and I'm going to keep with that. And so I've never been a big drinker, but I cut out all the alcohol. I hydrated. I just really amped up my diet with a lot of leafy greens and all of those things that are good, because I wanted to go into that surgery with, just guns blaring. I wanted to come out of it.
Brandi, I trained a lot of professional athletes in my day, and I wish you had spoken with many of them prior to surgery, because you set the pace perfectly.
Well, I didn't know it at the time, but this is really a thing. Like, I think it's in Pittsburgh. I want to say University of Pittsburgh, but other centers too. They have these programs where they actually train people for surgery. When people have the luxury of knowing that they're going to have surgery soon, doctors can put them on a program where they're getting exercise, eating a better diet, getting better mobility, all those things, because there's evidence to show that it improves your recovery and it makes it faster, and it saves healthcare costs, obviously. So I wanted to get back to my life as quickly as possible, and doing that. And also, through another kind of path of research and self-reflection, I decided to skip the cosmetic reconstruction as well. So I want to just represent all the flat sister survivors out there. We're living flat. I didn't know this was a movement until I started researching.
And what made you decide this?
So the more I learned about the reconstruction, the more apprehensive I became. When I first started, it was kind of a joke between my girlfriends and I. They kept saying, well, you're going to be 50 and you're going to have new perky breasts, just like a 30-year-old. And your insurance will have to pay for it. And what I learned is that it's absolutely not like a breast enhancement. When a woman goes in to get silicone implants for a breast enhancement, they're putting a little pad in over on top of what you already have to give you a boost. But when you're getting a cosmetic reconstruction from a mastectomy, they're cutting everything off and then they're rebuilding it totally. And what you're left with is maybe a very nice looking set of breasts, but they have no sensation in them at all. So you don't really get the benefit of that. They're just numb. the implants don't last forever. So even the plastic surgeon told me every 10, 12 years, you may need to come in and get them replaced. And then that's more surgery, as minor as it may be. And then
There is no minor surgery.
Exactly. And I don't like surgery. And so the other issue was that the silicone implants have what they call a black box warning on them, which is the most, I guess, severe warning that the FDA can put on a product. And it carries a small risk of other types of health issues, small, but a significant risk, significant enough that they need that black box warning. And for me, health was my number one priority. And I thought, why would I go to all this trouble to get a double mastectomy only to introduce something into my body that carries a risk of other issues? And if I get a recurrence of cancer, it's going to be harder for me to see and feel those lumps when I have an implant over top of my chest. And all because I want to do something that looks, I guess, socially acceptable, if you will. And so
more power to you.
I just switched it, and it allowed me to get through much more quickly with one surgery. I was one and done.
And when was that one and done?
I had my surgery July 1st.
And how are you right now, 5 months later?
I feel so good. I can't believe my good fortune. I just, when I was going through the research and trying to figure out what the typical recovery time was for a double mastectomy, it was all over the place. Some women take months to recover and others take just a couple of weeks. And what I found, going back to health and fitness, is that the common thread for women who recover quickly are those that are in good health going into surgery. So for me, it was maybe 5 days after my surgery, I had the surgical drains pulled out. And my surgeon told me, again, Dr. Mateo said, when those drains come out, there is no reason why you can't go to the gym and walk on a treadmill or use a recumbent bike, something where you don't have to move your arms, but you can work up a sweat and you may need to take a nap after, but you should be moving. And so day 5, I got the drains out. I wrapped an ACE bandage around it and put on a tank top, and I went to the gym and did the bike. And I never looked back. Within a couple of weeks, I was back to my CrossFit gym, Kana Fitness, and I was doing very, very light weights. I wasn't allowed to lift heavy, but I could do light. And the coaches there were wonderful at suggesting things and getting creative about, hey, you can't do this whole group of exercises, but you can do all of this. And it's focusing on what you can do.
I love you. Wow, this is just fabulous. And so right now, would you say you're 100% or 110%?
I would say mentally, I feel like 150% because I feel like there's no way to go through something like this without it changing your entire outlook on life. And it's changed my whole outlook on life. I feared this disease since I was in my 20s. And I had it and I came through it this time. I hope to never have to go through it again. Physically speaking, I would say I'm probably 90%. I can do a handstand against a wall. I can lift my arms up. I can lift weights, but I do still feel some tightness in my chest and I still have to work on more mobility than I did before, but it doesn't hurt. And I almost feel like there are days when I wish I had been born without breasts because as far as fitness goes, they were just getting in my way. So
yeah, but right now you're a role model for many, many, many people. So if you were born without breasts, you wouldn't be this mentor to everyone who's listening to you right now. Thank you, Brandi. Thank you.
Compliment. Thank you.
Now stay here because I want to hear the questions you have for Dr. Dambro. Mm-hmm. Doc, come on back, please.
Okay.
Hi, Dr. Dambro.
Brandi, you're awesome. I want you to be a speaker for Making Strides Against Breast Cancer. So Diana's on here. Diana, grab her. You're just phenomenal. I mean, you're a cheerleader for anyone who has been recently diagnosed for breast cancer, going through everything they're going through. You're a phenomenal cheerleader. You really are. I applaud you. You're my hero.
I applaud you too, because I know how difficult your job is to call women up and tell them the news that they don't want to hear. And they hear it in your voice before you even say the words, I'm sure.
And I guess, what I would say to you is in response to that is it's even more difficult. I mean, that is a difficult part of my job. I think the most difficult part is trying to convince women to come in and get it done. We even have patients who you look at their mammogram, their breast ultrasound, their breast MRI, and you know that there's a cancer there and it needs to be biopsied. And women, very few, thank God, who refuse to have the biopsy done. Again, it's about going back to what we said before, Pat. It's all about education. Anyway, questions, hit me.
Go ahead, Brandi.
So one of the things I wanted to ask was about the mammography versus the MRI. So for me, either the mammogram missed my tumor in November or my cancer started growing. I don't know how fast growing my DCIS was, but it seems like the mammogram missed it, the MRI picked it up. And do you feel like the MRI is going to become more mainstream for people? Because almost everyone I talk to doesn't know anything about what I was
breast
doing.
MRI, yeah. Okay. So, the thing is, it's not that the mammogram missed your breast cancer. It's, you had mentioned yourself that you're either category 3 or category 4 for breast density. So the more dense that the breast becomes, mammography decreases its sensitivity. It's not because it's missed. It's just because it can't be seen with all that dense breast tissue. That's why there's adjunctive. The word adjunctive means in addition to breast mammography and breast ultrasound, breast MRI. So the sensitivity of breast MRI for detecting breast cancer is around 96, 97%. There's nothing better. So your question would be like, well, why don't we just get MRIs and not screening mammograms? Because there are some cancers which are only seen on the screening mammogram and not the breast MRI. Breast MRI, while sensitive, is not very specific. So you end up maybe having unnecessary biopsies based upon the MRI. So a lot of times when there is a finding on a screening, your fast breast MRI, which is what we do for patients who are high risk, is that then you go back and you have a second look ultrasound to see if you can find what it was that MRI picked up that looks suspicious, and see if you can find an ultrasound. So now I attended an international conference of some of the gurus of breast MRI. Their thought is that we might see, maybe not during my career, maybe in the next 5 years or so, we're going to see that patients who are at extremely high risk and who have extremely dense breast may be screened first with MRI and then go back to having the mammogram done. We're just not there yet. You also have to consider the efficacy of screening millions of women with MRI, as opposed to how easy it is to get a screening mammogram done. So still the gold standard is screening mammography, then possibly additional imaging with ultrasound or breast MRI.
Yep.
Now, I do want to go back. I do it now, since you mentioned the bilateral mastectomy, okay? But I did want to mention that, say you did not have the mastectomy, okay? Say you just had a lumpectomy or you conserved your other breast. Now, the newest recommendation that's out there is that any woman who is diagnosed with breast cancer at the age of less than 50 and or who has dense breast is also screened, even though she's had cancer, is also screened with MRI in addition to her mammogram every year. So that's a new recommendation. In your case, it doesn't necessarily fall because you had the bilateral mastectomy. But I just want past listeners to realize that it's like, just because you've had breast cancer and you're getting your screening mammograms done, if you fall in that category of you were diagnosed at the age of less than 50 and or you have dense breast, it's also recommended that you get screened with screening breast MRI annually. And you can get the fast MRI, which is a few less steps, but it's still as sensitive for detecting the breast cancer.
And Brandi doesn't need any of that.
No, in Brandi's case, the other thing too is something I wanted to mention was that, and she was very astute in saying the lowest risk. By having the mastectomy, it decreased her risk significantly. You'll notice that she didn't say 0, because it doesn't. A bilateral mastectomy does not reduce your breast cancer risk to 0. There's always some breast tissue that's left, along the rib cage. There's also the recurrence, maybe it goes to the lymph nodes or something like that. So having the bilateral mastectomy does not necessarily reduce your risk to 0. In Brandi's case, if she has a lump, she doesn't have the implants. If she has a lump or something like that, more likely in the armpit, in the axilla, she might feel a lump. Then she might have ultrasound followed by MRI. It just depends on the clinical presentation that she has, or anyone like her.
So Brandi, you still do your own self-testing?
I do, and I can also see visibly what's going on, because it's very flat. I asked for what we call an aesthetic flat closure, which means there's no skin left behind. It's very smooth, so I can detect those things. And I think I think the other factor, you asked me what was one of my deciding factors about getting the mastectomy and going flat. And one of them was, and the plastic surgeon actually said this to me. He said, look, if you get a reconstruction, you may still need some imaging once in a while with an MRI or something. And, you know, you told me that you are anxious every time you go in for a mammogram and an MRI. And he said, and those times between those things are short. And he said, if this is going to be a quality of life issue for you, that's something to figure out. And so this also emotionally decreased my anxiety level, which was one of the many deciding factors for me.
It's not all cut and dry, Pat. It's kind of, you know, unfortunately, she's had some really excellent medical coaches who have helped her. In other words, like, what's important to you? What's your lifestyle like? All of those things go into the factoring of what you're going to have done once you have the diagnosis of breast cancer. So Brandi's right on. I mean,
wow.
Anna, we need her on our board.
Well, between the two of you, what a great 1-2 punch. Every woman should hear this hour between the two of you. It's just wonderful. Brandi, do you have any other questions for Dr. Dambro?
I don't think so, except I would say, what is your advice to women when they're dealing with physicians? Because for me, I always felt like I was such an advocate for my own health, but I almost feel like they cringe when I come in because I do know just enough to be dangerous. How do you strike that balance between asking the right questions and also placing the expertise where it belongs, which is with you?
Okay, so, and I will tell you that there are referring physicians who don't read our reports. We recommend breast MRI in certain population of patients, and referring physicians, for whatever reason, don't look at our recommendations. And then you'll meet the patient the next year, or I met a patient at a conference who said, how come I was never told that? How come I was never told I'm at high risk and therefore I need a screening breast MRI? And so you have to be, you, meaning the woman, has to be a patient advocate. Someone like yourself is. A lot of the women, they have access to reports on the patient portal. They can go in and see their own report, see what the radiologist recommended, and then go to the referring physician and say, hey, look. And you will not find a primary care physician who will refuse a patient if she demands to have something done. And unfortunately, it's for liability reasons. But, you know, in other words, like, we're going to do what you want. We have patients come in who, you know, like, this is not what's, but if the patient says, yes, this is what I want, you do it. If nothing more than peace of mind. In fact, a lot of times I will tell a patient about screening breast MRI, the fast breast MRI, which you say, even if your insurance doesn't pay for it, it's not that much out of pocket. Peace of mind is also important. Whether or
Peace
not
of mind that's the ultimate is peace of mind.
Right. So whether it's indicated technically by you know, everything that we do, maybe it's indicated emotionally. So I will tell the patients, if I were you, I'd go get it done. Then you don't have to worry about it. Like you said, you don't have to worry about it for 6 months or next year. And there are patients who find some peace of mind just having that done.
Yes.
Diana, come on, Diana. We have several minutes left, but I want to see, she probably has some questions from our audience. Diana?
I do have a question, and I believe this is probably for you, Dr. Dambro. If a typical person who has a clear mammogram doesn't come back for a year, normally it's an every year mammogram. Brandi was going for the MRI 6 months in between. Is there something we should be asking our physicians to be included in that protocol, or is that something that, knowing our history, our physicians would recommend?
So I don't know the last point. I don't know whether they would recommend that. If they read our reports, they'll see it. Now, the 6 month thing is up to the patient. So sometimes, they'll have the screening mammogram and the breast MRI the same day, or, within the same week, which is fine. In Brandi's case, when you're doing it, you're separating the 6 months. So if there's anything, especially with women who already have a history of breast cancer, and they're like at a high recurrence, they're at a high risk for recurrence, is if you do the mammogram and 6 months later you do the screening breast MRI, if anything happens in that 6 months, you're going to pick it up with the MRI, and then 6 months later you're going to have the mammogram every 6 months. So there's no set protocol for doing it every 6 months versus at the same time. Again, it's more a conversation that either you, the breast imager, have with the patient and/or their primary care physician. Which way? But
Dr. Dambro, from your medical point of view, you don't see any difference either or.
No, I mean, you could have it both done at the same time, or you can have them done 6 months apart.
One more question, Diana. Anything quick?
Right. So, Brandi, your choice in your treatment of having a double mastectomy was not the first option presented by your doctor. So did you receive any kind of pushback as far as wanting to take that more aggressive approach?
I didn't. She is a very progressive surgeon, and she did pause for a moment. I said, let's back up and talk about this other thing. And she said, oh, yes, that's an option. And she said, I don't present that initially because we try to do the least invasive and the most conservative approach that will yield the same low risk of recurrence. But yes, we can talk about that. And she did not push back. And even when I called her and said, you know what, I changed my mind, I'm not doing the reconstruction either. She said, that you're part of a growing number of young women who choose this option. And she said, I've done many of them. I'll show you pictures. We'll make sure we're on the same page. And she said, I think it's a wonderful option for you. So the answer is no. And I would say I had the most phenomenal team of healthcare providers I could have had. I had the most supportive family, the most supportive workplace. My boss told me, your job now is to get well and get past this. I had health insurance. I had money to pay for what health insurance didn't cover. I had everything going for me. And it makes me sad that it's not that way for everyone. But I had it and I was fortunate. But yes, I would say no pushback whatsoever. It was all great.
Awesome.
Thanks, Dana. Brandi Plutnik, virtual hug. Thank you. Thank you for sharing and being such an advocate. And would love to have you back again. Dr. Tim Dambro, I wish you were my doc. What a great attitude. I love your energy and I love your intelligence.
And the sweatshirt.
Oh, yeah. Between the two of you, as a matter of fact, I'm going to make sure my daughter, my granddaughter, my wife, everyone sees this hour, if nothing else. Thank you. Thank you for joining us here today on our Healed Gathering. And I like to end the gathering just with a little attitude of gratitude, a simple one-line prayer to thank you for the grace in helping me to welcome what is happening right now. Right now. Thank you for the grace in helping me welcome what is right now. Brandi, Dr. Dambro, Diana, Scotty, our producer. Thank you all. Mwah. Peace.
Thank you.
Thank you.